Good morning, everyone, and a very warm welcome to our day 4 of CRAN's My Colorectal Cancer Coach Summit 2026. We are absolutely thrilled to have you join us again this morning. Thank you so much for choosing to be with us. My name is Christopher Mamali, and I am the National Patient Programs Manager here at CRAN, the Colorectal Cancer Resource and Action Network. And I am as well, a three-time early age onset cancer survivor. I'm joined this morning with our visionary and ever dedicated president and CEO, Filomena Servideo Italiano. Filomena, I'd love to turn it over to you to welcome our coaches and viewers this morning.
Thanks very much, Christopher. Good morning, my friends, and welcome. Welcome to day 4 of CRAN's My Colorectal Cancer Summit, an expert-led event that is serving as the capstone initiative for this very special month in which we find ourselves, Colorectal Cancer Awareness Month. And on that note, a very happy Colorectal Cancer Awareness Month to you all. For the past 3 days, a lineup of stellar experts from across Canada have been delivering empowering and evidence-based presentations across a diverse range of topics that actually matter to patients and caregivers. The first day's sessions were dedicated to addressing management of earlier stage disease, and the second and third days then started to migrate into addressing the management of advanced and metastatic colorectal cancer. We have been pleased to see that the sessions have been nicely attended virtually by you all. In addition to training and certifying our colorectal cancer coaches, whose commitment to the program is truly unparalleled, we also believe that this summit stands to educate our colorectal cancer community. Patient education is extremely important to us and is a critical step towards achieving patient empowerment and taking back a sense of control that was surrendered during the delivery of the patient's diagnosis. We want to provide free virtual access to reputable, expert-led, evidence-based information about topics that are of particular interest and relevance to the community, because the education can enhance the patient's experience, reduce fear, and can certainly provide patients and caregivers with the tools they require to move forward in their journey with confidence and competence. This was our intention when we decided to open up the summit to our patient and caregiver population. Today, my friends, we have secured key opinion leaders who will be addressing the surgical management of colorectal liver metastases, clinical trials, the radiotherapeutic management of metastatic disease, how naturopathic medicine can address colorectal cancer treatment-induced toxicities, and how ctDNA, minimal residual disease, delivers on personalized cancer insights. And a particular treat for you today is the fact that CRAN's very own Christopher Mamalidi will be speaking to CRAN's unique patient resources and programs designed to help educate and support colorectal cancer patients. So please enjoy what we have scheduled for you today. The lineup of speakers are truly outstanding. Back to you, Chris.
Thank you very much, Filomena. And before we get going, everyone, I want to start a little bit with some housekeeping, if that's okay. The summit is being recorded. Viewers cannot be seen or heard, so there's no need to worry about your mic or your camera. All registrants will receive exclusive early access to the recordings before they become publicly available. To view today's agenda, click on the Sessions tab. You can see it highlighted there. In the top right-hand corner of your browser, across the top navigation bar, users can also learn about our expert speakers, visit our sponsor web pages, and see bookmark sessions within their personal itinerary. Please leave the lobby open in your browser during the summit. When each session ends, you'll be prompted to rate the session. Please take the time to do this. It's so very important for the purposes of improvement. And then you'll need to return to the lobby to join the next session that's of interest to you. In the afternoon, you'll join using a fresh link that was sent via email this morning. Should you experience any technical difficulties at all, Our team are ready to support you. Please reach out to our communications manager, Alyssa Salmon, should you require any assistance at all. Very quickly, I think it's always appropriate to share about the heartbeat of your organization, our motivations. And for those who are participating or joining this morning who may be new, I'll briefly introduce our organization. The Colorectal Cancer Resource and Action Network, or simply known as CRAN, originated as a grassroots colorectal cancer information and support group back in August 2006, 1 month after the passing of Philomena's father, who was afflicted with widespread metastatic disease. Today, CRAN has proudly become a national, not-for-profit, patient-focused organization. And I can tell you personally that was so important to me when I joined. We're governed by an expert board of directors, and we're counseled by an expert medical and scientific advisory board, of which many members are generously participating in this event. At CRAN, we have 2 patient advisory councils, one of which is dedicated to the under 50 patient population, whose past experiences with the disease help inform our program development. This is important to ensure our services and programs are relevant and meaningful. In terms of our mandate, we champion the health and well-being of Canadians touched by colorectal cancer and others at risk of developing the disease. And we do this by providing 3 main pillars: support, education, and advocacy to both patients and their caregivers, which is a very important distinction. And that's to help improve a patient's quality of life, as well as to attempt to improve their longevity. CRAN has expanded its patient-focused mandate to serve multiple tumor types through our HDA's patient evidence submissions, educational events just like today, advocacy initiatives, and some of our patient programming to ultimately reduce the burden of cancer in Canada. This is ultimately our mission. Here on the screen today, you will see our amazing My Colorectal Cancer coaches. And I'd like to take the opportunity, we take every opportunity to try to highlight them as much as possible. Our dedicated coaches are here. They're ready to guide you as you live with or beyond cancer, and will offer compassionate support and evidence-based information. And this is so important for us on this journey to have that support. The earlier you can reach out to us, the better. The earlier we can support you, the better we can be of assistance. So if you would like to connect with your very own coach, please do not hesitate to reach out to myself or any team member, and we'll be happy to refer you to any of these wonderful coaches. So please reach out anytime. Today, we will begin the summit with a presentation on the surgical management of colorectal liver metastases with Dr. Paul Karanicolas, followed by Empowering the Journey, How ctDNA MRD Delivers Personalized Cancer Insights by Serena G. Ursu. We will then have a short break to reset before heading to our midday session on the radiotherapeutic management of colorectal cancer by Dr. Helena Lukovic. Following our lunch break, we hope you get a moment to ultimately relax and eat. Dr. Eric Marsden will walk us through naturopathic medicine, addressing colorectal cancer treatment-induced toxicities. Dr. Michael Rafel will then discuss clinical trials in the medical management of colorectal cancer. Lastly, we finish the day actually with our very own Cassandra McCauley, our Chief Research Officer, who will be walking us through CRAN's resources and programs today. Please do get comfortable with your pens, papers, and tablets, laptops, or whatever it is that you prefer to note take with. Following each expert presentation, our cancer coaches will enter a 15-minute closed and interactive discussion with our experts, and that's so we can ensure adequate knowledge, translation, and content acumen. During these gaps in the schedule, we encourage our viewers at home to take an additional 15-minute movement break or maybe grab a snack. Okay, so to start our presentations and our sessions today, I will note that this first session is a recorded presentation, and this is with Dr. Karanicolas under the title, The Surgical Management of Colorectal Liver Metastases. Dr. Karanicolas received his MD degree from the University of Western Ontario in 2003 and his PhD in Health Research Methodology, Clinical Epidemiology, and Biostatistics from McMaster University in 2008. He completed his residency in general surgery at Western University in 2009 and a fellowship in surgical oncology at the Memorial Sloan Kettering Cancer Center in 2011. Dr. Karanicolas is a surgical oncologist and scientist at the Adet Cancer Center at Sunnybrook Health Sciences Center, and holds a professor title at both the Department of Surgery and the Institute of Health Policy Management and Evaluation at the University of Toronto. The overarching theme of his research program is the development and conduct of clinical trials in surgical oncology. Dr. Karanicolas is also the surgical lead for the hepatic artery infusion pump chemotherapy program at the Adet Cancer Center, the only such program in Canada, and one that I know Filomena Servilio Italiano and CRAN advocated for as well for years. I will also note that Dr. Karanicolas is an esteemed and respected member of our medical advisory board. Without further ado, it is an absolute honor to pass to you, Dr. Karanicolas.
Okay, hello everyone, and thanks very much for the invitation to present today on the surgical management of colorectal liver metastases. And I'm sorry I can't be with you live today. The scheduling just didn't allow it, but I'm very happy to have the opportunity to share my perspective with you. This is my only current disclosure. So the objectives that I was hoping to cover in the next half hour or so are regarding the surgical management of colorectal liver metastases, and specifically beginning by chatting about resectability, which is a lot of what we talk about, and just sharing a little bit more about what we mean by this. So which patients are resectable and what the optimal timing of that should be. And then a few specific niche areas. So the role of ablation as part of an overall resection plan, the role of chemotherapy for patients who have resectable liver metastases, the role of liver transplantation and hepatic artery infusion pump chemotherapy, which are two niche areas for more advanced disease, and finally, the evolving role of circulating tumor DNA in patients with resectable metastases. So as you know, colorectal cancer has a strong preponderance to metastasize to the liver. So about a third of patients with colorectal cancer will develop liver metastases at some point during their disease trajectory. For many patients who have liver metastases, the liver is in fact the only site of spread. So there is a unique biological factor that encourages colorectal cancer to metastasize specifically to the liver. And in some patients with liver metastases, it's really the only site of disease or the major site of disease. And in those patients, we have quite strong evidence that if we intervene on the liver specifically and we're able to control or ideally eradicate the disease from the liver, patients will survive longer and in some cases even be cured of their disease despite the metastases. And this is really a unique factor of colorectal cancer. Colorectal cancer is really the only cancer that is still potentially curable when it spreads to the liver. So most cancers, when they spread to the liver, are not curable. And in fact, we don't do any liver-specific treatments. We treat them only with systemic therapies. But colorectal cancer, as I mentioned, has biologic properties that even when it spread to the liver, it can still potentially be cured. So we generally think of liver metastases in three categories, and that really influences the way that we think about treatment of it. So some patients have what we would consider local disease in the liver. And so that's a limited number of lesions, anywhere from 1 to 10 or 15. So there's not an absolute number, but it's a limited number of lesions that can be removed or treated with some local treatment option. And those might include resection, so actually removing a piece of the liver to remove all of the metastases within it. ablation, so thermal ablation, so treating it with heat, either microwave or radio frequency ablation, where we put a probe in and we burn the lesion or a few lesions. Stereotactic ablative body radiotherapy, so external beam radiation to one or a small number of lesions. Those would be the main local treatment options. Those would be our priorities or the first sort of line of defense if they are technically possible. For some patients, they may have too widespread disease within the liver to allow those local treatment options. And in those cases, we can consider something called regional therapies, and that involves treatment through the hepatic artery of all disease within the liver. And there's a few different ways that we can do that. We can do that by putting a pump in, a hepatic artery infusion pump with the catheter going into the artery here and delivering chemotherapy to all of the liver. So that's one mechanism. And there's two other treatment options that our interventional radiologists would generally do. Those are called TARE or TACE. And TARE stands for transarterial radioembolization, so putting radioactive beads in that go all throughout the liver. And the other is TACE, so transarterial chemoembolization, where we put glass beads in that have chemotherapy attached. So again, two ways of treating lesions within the liver when disease is confined to the liver but is too widespread to allow specific local treatment options. And then the third category of patient is patients who have more widespread disease outside of the liver. And in that situation, really we think of it as systemic disease, and therefore systemic therapies are best. And those would be traditional chemotherapies or immunotherapy or targeted therapies. And I won't deal more with those in this talk. Those would be treatments that our medical oncologists would specialize more in. And this is just a different way of showing that same figure to really focus the point that every patient is unique and really the optimal treatment differs for a specific patient. So whereas most of what I do is local treatment, so is surgical resection, that's not the best treatment for every patient. And it's really about tailoring the optimal treatment for the specific patient. So we'll talk a little bit more now about liver resection, which again is most of what I do, and is the goal in many patients. When the disease is confined to the liver, the first question that we always ask is whether or not it is technically possible to remove all the disease from the liver. Because we know very well that removing all the disease extends patient's life and is the only chance of curing a patient from the cancer. So our goal when we see a patient is to achieve resection when it's possible with as little morbidity and risk as possible. And the way that we've gone about that has changed over the past several years. This is still a relatively new concept in the overall treatment of colorectal cancer. This is really one landmark publication that's about 20 years old now. And even at this time, certain doctors question the role of liver resection because, again, with traditional paradigms, once cancer has spread anywhere, and particularly to the liver, traditionally people thought that there was no role in local treatment or surgery, and really the only role was for systemic therapy. And what this study showed in a large number of patients was that if you can actually remove all of the disease, patients have a much better outcome than if they did not have surgery to remove it. So this shows an overall survival on the left-hand side here of about 25%. So the likelihood of being cured of cancer, if we're able to remove it, is about 25%. And that number stays the same. So most patients, unfortunately, still will have recurrence after resection, but there's a reasonable number here who will have long-term survival after resection. And you can see we can stratify based on a number of factors. This is one stratification score here called the clinical risk score that shows in patients with sort of the best prognostic features, the cure rate is closer to 30 or 35%. But even in patients who have the worst prognostic scores, they still have a chance of being cured of around 15 to 20%. So when resection is technically possible, it is generally the treatment option that we suggest for patients. So with that, how do we define resectability? Well, there are technical considerations. So that's can we do it? Can we remove all the disease from a patient? And then there's the oncologic resectability criteria, and that's the thinking about whether or not it's the right thing to do. Will it help patients? And we need to consider both of them. The oncologic factors I'll talk about first, that has to do with features such as whether or not there's cancer outside the liver. And so generally speaking, if the cancer has spread to sites outside of the liver, we don't really think it's valuable to resect the disease within the liver in most situations. There's some exceptions to that. So for patients who have very limited lung metastases, they tend to be quite indolent, and we would still recommend liver resection even in that context. But for the most part, patients with other sites of disease outside of the liver, we generally would not recommend liver resection. The best treatment would be systemic therapies. Other oncologic factors would be things like the clinical risk score. Although, as I mentioned, even with patients with the highest or the worst clinical risk score, they still seem to benefit from liver resection when possible. We use things like biomarkers now, so things like RAS mutations or certainly BRAF mutations, which I'm sure the medical oncologists will speak about during these sessions, are also biomarkers that will dictate the prognosis after liver resection. And then response to systemic therapy is an important oncologic factor as well. So we take all of those into account when crafting a recommendation for liver resection or not. But the first question we ask is whether or not it's technically even possible to do it. And what we look for when defining resectability is not how much disease is present or how many lesions patients have or how big they are. What we look for is whether or not there's enough liver that can be left behind to allow all of the disease to be technically removed. And we do think that it's important to treat all of the disease. We would not remove 95% of the disease and leave a little bit behind. Unfortunately, we don't think that there's any value in doing so-called debulking. It's really an all or nothing phenomenon. So if we can remove all the disease, we would do so. If we cannot, we would not recommend it. And when I say remove, I'm including ablation as part of that, because ablation is an important part of extending the boundaries of what's resectable. And so generally what we're looking for is to leave behind a piece of liver that has no cancer in it, that is at least 20 to 25% of the optimal liver volume. That's really the minimum that we need to be able to leave behind in order for a patient to be able to function and have a good long-term function. That's a healthy liver. Once patients have had some chemotherapy, we know that it affects the liver. So in patients who've had some chemotherapy, which is actually the bulk of patients in this setting of extensive colorectal metastases, then we need to leave behind at least 30 to 35% of the liver. And in patients who have pre-existing liver disease or even cirrhosis of the liver, that number is even higher. It's closer to 40 to 45%. So that's the main thing that we're looking for. And we actually have ways of taking patient CT scans or MRIs and calculating the volume of liver that will be left behind. The second aspect of that is we need to, in addition to leaving behind an adequate volume, it's important that the liver that we leave behind is high functioning. So it needs to have blood flowing to it, it needs to have blood draining it, and it needs to have bile ducts draining it. So the liver is a bit like the body, that it's a bit of a skeleton, and we have those blood vessels and bile ducts flowing into it and draining it. And we need to make sure that we can preserve sort of that skeleton of the liver in order to have it functioning afterwards. So it is quite a complicated assessment for patients that have extensive disease. For patients who only have one or two lesions, it's a much simpler assessment. But for patients with extensive disease, it can be quite a complicated assessment to see whether or not we can remove all the cancer while leaving enough functioning liver behind. And there have been a few studies to look at whether or not surgeons agree on this. And this is one study that I'll just show you the results briefly here. The bottom line is that unfortunately, even experienced liver surgeons do not always agree on whether or not liver metastases are technically resectable. So again, this is one study that looked at each of these bars as an individual patient, and this is a study that asked a panel of surgeons, expert liver surgeons, whether they would consider the liver metastases resectable or not. And you can see green are surgeons who said, yes, it's resectable. Red are surgeons who said that it's not resectable. And so this was a study that was meant to enroll only patients with unresectable metastases. And you can see that it's only about half of the patients where there was agreement that indeed the disease was unresectable. In the other, about half of patients, at least some surgeons, and in some cases, actually all surgeons, felt that the disease was resectable, even though these patients had been enrolled in a trial meant for unresectable metastases. So this really speaks to the importance of seeking an opinion from an experienced liver surgeon, and potentially even getting a couple of opinions from liver surgeons about the technical resectability of liver metastases, because again, there's often disagreement with respect to that. It's quite a nuanced assessment. I'm going to switch gears now and talk a little bit about ablation. So as I mentioned, ablation is an important tool for us that over the past 10 or 15 years has really pushed the boundaries of what is resectable and what is not resectable. This is one study that we did a couple of decades ago now that shows that patients who have bilobar metastases, so that used to be a contraindication to liver resection, having metastases on both sides of the liver. This compares patients who had resection on both sides as the black line to patients who had resection and ablation as the blue line. And you can see that the outcomes are equally good in both arms. So this allows us some confidence to be able to treat patients with ablation to really push the boundaries of what is resectable disease. Recently, there's been some studies that have pushed this even further and asked the question for patients who have resectable disease, should we be doing more ablation to really reduce the extent of surgery and therefore make surgery hopefully safer and less morbid? So this is a trial called the Collision trial that was published just last year that basically randomized patients who had resectable disease to have two strategies, a resection strategy or a resection plus ablation strategy for specific lesions, small lesions. And just skipping forward to the results here, what you can see is that, again, similar to the other study that I showed you, patients basically who had an ablation strategy had just as good overall survival and just as good progression-free survival as patients who had a resection alone strategy. And when we look at adverse events, you can see patients who had an ablation strategy had less adverse events, so less complications from the procedure compared to patients who had surgery alone. And so putting this together, what we can conclude is that a treatment strategy that incorporates ablation seems to achieve as good survival, so as good cancer outcomes as resection alone, but with less morbidity to patients. So on the basis of this, again, it provides even more comfort to incorporate ablation quite routinely into our overall treatment strategy for patients where appropriate. We still don't know whether ablation is quite as good as resection for patients who have very limited liver metastases, so that trial didn't really answer that. Or we also don't know what the boundaries are for ablation in terms of the maximum size that can be safely treated and location of tumors. We also don't know specifics about the techniques of ablation that we should be using. So those are all questions that are being asked now. And there is a trial that's being done in Norway currently that has just completed accrual, and we should have results in the next year or two that will answer some of those questions. So we're looking forward to this, but we are currently using ablation a lot more in our treatment approach, and it has really extended the limits of patients who can be safely treated with local treatment options. So just to summarize the local therapies for patients with colorectal metastases, we do think for patients with liver-only metastases that treatment with local therapy should be the goal. That might be resection, that might be ablation, or in some cases it's also radiation. This is a radiation plan. And for patients with even a little bit of extrahepatic disease, so spread outside the liver, still local therapy should be at least considered. And again, patients who have lung metastases are the main group who we would consider that in. Patients who have a little bit of peritoneal or omental disease, particularly ovarian metastases, still may have some benefit if all of the peritoneal disease can be treated. And generally speaking, retroperitoneal lymph nodes or other distant sites of disease would have the worst behavior. And we generally would not do a liver resection on someone with those sites of disease. So switching gears a little bit further now to talk about other treatments and how we integrate them into liver resection. This is a very complicated group of patients who have their primary cancer in situ, especially when it's in the rectum and it's spread to the liver and potentially to other sites. You can see all the general treatment options that we have to consider. We almost always would think about surgery for the colon or rectum. Sometimes if patients have a complete response in the rectum, we would not remove it. I'm sure there's talks about that as part of these sessions. But we think about liver surgery, we think about radiation, we might think about surgery in other areas, we think about systemic therapies. So incorporating all of these together often requires, many doctors to get together. And so I think it is important to be treated at a center of excellence where all of these specialties are represented and the doctors talk frequently. Specifically thinking about chemotherapy now, conceptually, we know that chemotherapy works well in stage 3 colorectal cancer. It's the standard of care, and it has an important role to play in preventing cancer recurrence in that patient population. We also know that chemotherapy has a very important role to play in patients with stage 4 colorectal cancer when resection is not possible, and it certainly extends life in that situation. So conceptually, there's good reason to believe that chemotherapy should work in patients with resectable colorectal cancer. Unfortunately, the evidence doesn't really support that. And I'm going to show you two main trials that have asked this question about the role of chemotherapy in patients with resectable liver metastases. This is the first trial called the EORTC trial. It was published almost 20 years ago now. And this is a trial that randomized patients with resectable liver metastases to receive perioperative FOLFOX chemotherapy or to receive no chemotherapy at all and just have surgery. And what this trial showed was the primary outcome was progression-free survival. And initially it looked somewhat promising. So at 3 years, there was a suggestion that patients who received chemotherapy had improved progression-free survival compared to patients who received surgery alone. So the chemotherapy arm here is the green line, and the surgery alone group is the blue line. The trouble is when we followed patients further and particularly looked at overall survival, which is ultimately what we care about, there was absolutely no difference seen in terms of overall survival between patients who received chemotherapy here in the red line versus patients who received surgery alone in the blue line. So chemotherapy seems to improve the time until the cancer recurs, so that's progression-free survival, but that does not seem to translate to an improvement in overall survival, which is what we really care about. So it just seems to lead to earlier treatment of metastatic disease, but it doesn't seem to prevent the cancer recurring. So based on this, it's hard to recommend chemotherapy, at least from the perspective of improving survival. So investigators then did this trial called the New Epoch trial that said, well, maybe the chemotherapy that we're using isn't good enough. Let's try comparing chemotherapy, regular chemotherapy with FOLFOX, to chemotherapy with FOLFOX plus cetuximab. And unfortunately, this trial showed even worse results, where the patients who received cetuximab had a statistically and clinically worse progression-free survival and overall survival compared to patients who received FOLFOX alone. So on the basis of this, we feel quite strongly that patients who have resectable disease should not receive cetuximab in the perioperative period. And the final trial that I'll show you regarding this was done in Japan, is called the JCOG trial, published a few years ago. This looked at adjuvant FOLFOX chemotherapy compared to no chemotherapy. So this is after liver resection. And again, initially, when we just look at disease-free survival, initially the results look promising, where the chemotherapy group seemed to perform better than the patients who did not receive chemotherapy. But the problem is, when we look at overall survival, we see absolutely no benefit. And if anything, there seems to be a worse overall survival in the patients who receive chemotherapy compared to the patients who receive liver resection alone. So on the basis of this, we really would not recommend routine chemotherapy after liver resection for patients. There's really no evidence to support a benefit to receiving chemotherapy after liver resection. And we know that chemotherapy does increase complications at the time of liver resection. And there's a relationship in terms of the more chemotherapy the patients receive, the higher the rate of complications after surgery. So we really try to limit the amount of chemotherapy that patients receive before surgery, and we generally would be quite reluctant to recommend chemotherapy after surgery. There's some theoretical advantages to chemotherapy, so we still use it quite regularly, particularly for patients who have extensive disease. So again, it does not seem to improve the likelihood of cure, but there is a role in patients who have more extensive disease. So it may have a role in downstaging, so reducing the extent of surgery that we need to do. It also allows us to get a bit of a test of the biology to see how aggressively the cancer is, and therefore make better decisions about whether a patient is likely to benefit from surgery or not. And it allows time to see a surgeon and get a plan and get a date for surgery. So it still has an important role to play, particularly for patients who have extensive disease and need staged surgery, need surgery for both the primary and the colon or rectum and the liver. Chemotherapy has an important role to play in getting patients through that process, but it does not seem to result in an improvement in overall survival or prevent the cancer recurrence compared to patients who do not receive chemotherapy. So overall, we're quite selective in terms of who we recommend chemotherapy to. And in patients who we do recommend chemotherapy, it's quite important to keep it brief, only 2 or 3 months, to really limit the toxicity to the liver. So I'm going to now shift gears to patients with more extensive disease who are not resectable and talk about 2 other treatment options for those patients. The first is liver transplant, which really would have seemed like a crazy idea only 10 or 15 years ago. But you can see this is the first publication that came out. Actually, it's been just over 10 years ago now, from Norway, where a relatively small group of patients, only 20 patients who had unresectable liver-only metastases, had liver transplant. So in many ways, liver transplant is the ultimate regional therapy because it removes the entire liver and gives patients a new liver. And what you can see here is that after liver transplant, this is this dotted line here, the SICA trial, most patients still have progression. They do develop disease again at some point. So the likelihood of being cured after liver transplant is still quite low, but very importantly, it tends to be slow-growing indolent disease that results in a very good overall survival still. So this is from this small study. Again, you can see that the overall 5-year survival was about 50 or 60%. So certainly as good, if not better, than liver resection, and much better compared to a similar patient population that had chemotherapy alone. So since then, there have been many other studies, and this area has really exploded since then. And there's even been a randomized trial that was published a couple of years ago in France that randomized patients who had unresectable colorectal metastases to have either liver transplantation or chemotherapy alone. Important to note, this is a very, very highly selected group. Let me go back one slide for a moment, because this is a common question and a common interest from patients who have unresectable liver metastases is transplant. And I would just want to emphasize all of these patients had resection of the primary tumor, had to have absolutely no extrahepatic disease. So not a single pulmonary nodule or a single spot anywhere outside of the liver. And they had to have response to chemotherapy for a minimum of 3 months. So they need to have stable disease or response after resection of the primary tumor for a minimum of 3 months here. They needed to have a low CEA and be otherwise very healthy to allow liver transplant to be done. So a very, very, very highly selected group of patients. But in those patients, there was a very clear benefit to liver transplant with really excellent results. Again, this is at 5 years, and you can see the 5-year overall survival greater than 50% and much, much better compared to chemotherapy alone. So important here to note, transplant is an excellent, excellent treatment option for patients who have unresectable colorectal metastases, who have liver-only disease that are able to have stable disease or ideally some response to chemotherapy. I'll skip over this. This, again, just makes the point that it really is applicable to a small number of patients. Again, in this trial here, done in France at large sites in France, there was less than 1 patient per site per year enrolled in the trial. So it just is a small number of patients that it's applicable to, but in those patients, it has excellent, excellent results. So the next thing to talk about is the role of hepatic artery infusion pump chemotherapy. So that's a program that we offer at Sunnybrook. We're currently the only site in Canada that offers this, although we've been working for several years with a few other sites to try and expand access to this. And I think hopefully within the next year or two, we will be able to offer this treatment at other sites in Canada, because it is a nice treatment option, again, for a selected group of patients. This is not a new treatment. You can see this is an initial publication from 1951, actually. So it's long been recognized that cancer in the liver, whether it's primary liver cancer or metastatic liver cancer, derives its blood supply from the arteries in the liver. And that allows for this unique treatment option, because the liver has 2 blood supplies. Most of the normal liver is supplied by the portal vein, and the cancer, as I said, is supplied by the hepatic artery. So when we give certain types of chemotherapy into the hepatic artery, almost all of it goes to the cancer itself and stays there and does not go to the rest of the body. So it allows us to give a much, much higher dose of chemotherapy to the cancer compared to what would be received by the cancer when it's given intravenously, like most chemotherapy is. So currently the drug that we use is a drug called FUDR. That's, again, an old drug. This is from 1983. So this is more than 40 years old now, this study that demonstrated that FUDR, a derivative of 5-FU, When it's given via the hepatic artery, almost all of it stays in the liver. So when we give a dose via the artery, we get about 100 to 400 times the exposure to the cancer compared to what we would get when it's given intravenously. So that's the best drug that we have, and that's the drug of choice that we use when we give this. So this requires an operation. It can be done by an open incision, or we now also do this robotically sometimes. So it requires an operation, though, where we put this catheter into the artery called the gastroduodenal artery that leads up to the hepatic artery, and that goes straight to the liver. And then we have a pump here. It's not called this pump anymore, but it's a similar pump that's about the size of a hockey puck that we put under the abdominal wall, similar to how a port would be located. It's just bigger than a port because it has an actual pumping mechanism. This is what the pump looks like. And again, this is what surgery would look like, or sometimes we can do this robotically, but we have a small incision here that the pump goes into. We always need to take the gallbladder out because otherwise we would have a strong dose of chemotherapy going to the gallbladder and causing problems. We always remove the primary tumor unless it's low in the rectum and there seems to be a complete response, in which case we might leave it in. And we test with blue dye to make sure that it goes to the liver and nowhere outside of the liver. So this again is a picture from surgery that shows the catheter going into the artery and going up to the liver. And this is what the liver looks like after we inject with blue dye. You can see how blue it looks. And that's how we make sure that it's flowing properly to the liver and it's not flowing anywhere outside of the liver, because that would limit our ability to deliver chemotherapy. And then we fill the pump every 2 weeks with alternating chemotherapy or just heparinized saline. And so patients do need to come into our cancer center every 2 weeks, and we follow them very closely to make sure that it's not damaging the liver. There's a number of old studies that I'm not going to go through in detail here, but just to show you that there is data that shows that we get a much better response rate in the liver. So the cancer definitely gets much smaller compared to intravenous chemotherapy. I won't go too much into this. And when we look at the response rate compared to other sort of modern combinations of systemic therapy, this is in the second line setting. You can see we get much better response rates here compared to systemic therapies alone. We had a consensus meeting that was run over 10 years ago now, and I won't go through this in detail, but just to say that this is what allowed us to start a program at the Odette Cancer Center at Sunnybrook. And this is our eligibility criteria that really hasn't changed too much over time. So again, patients who have unresectable liver metastases would be eligible for this. We treat all patients with at least one line of chemotherapy, at least to the point of stable disease, not to disease progression if possible. So we like to still put the pump in quite early. We know that the earlier we put the pump in, the more effective it is. So we like to put it in quite early in the first line setting. And we are limited to patients who do not have spread outside the liver, with the exception of very limited lung metastases. We always take the primary tumor out, as I said. These are just some characteristics of the patients we've treated. We've now treated about 120 patients over the past decade or so. So we treat about 15 to 20 patients a year. And you can see it's, again, quite selective, where it's about a third to a quarter of patients who we see where we end up recommending this and they decide to go ahead with it. And these are our general outcomes. You can see we get response rates in the vast majority of patients who we operate on and put pumps in. The goal is to get patients onto other treatment where possible. So about 15 to 20% of our patients go on to have a liver resection, and we've now had 7 or maybe 8 actually currently patients who've gone on to have a liver transplant after pump. So in the right patient population, it can be a nice bridge to liver transplant because, as I showed you before, patients need to have their primary tumor removed in order to be eligible to have liver transplant. And during that time of removing the primary tumor, there's a risk of the cancer in the liver progressing, and that would preclude liver transplant. So pump chemotherapy is a nice bridge to transplant in the right patient population where we can operate, take out the primary tumor, put a pump in to control the cancer in the liver. Ideally, we get to the point that we can do a liver resection and remove what's left, but if not, then we refer patients on for liver transplant if possible. So that's a nice sort of treatment paradigm that we've now been able to offer many patients. This is, as I said, is a treatment that's gotten much more popular over the past decade. So when we first started doing this, now almost 15 years ago, we were one of only 5 or 6 centers in the world doing this. Now there's over 100 centers in the world, and there's a hepatic artery infusion consortium that includes largely centers in the United States. That's the most common place for this. We're again the only center in Canada represented here, and then there's a few international centers as well offering this treatment. And there's now a randomized trial that is comparing this against modern chemotherapy. So we will have even better evidence that shows us whether this is effective or not and how effective it is, but it'll be a few years before we have results from this. So I'm going to wrap up now just briefly talking about circulating tumor DNA. It's a very hot topic that we're asked a lot about. And I'm sure you'll hear a lot about circulating tumor DNA from a few sessions during this workshop. I'm going to focus really on resectable liver metastases. This is a study that examined this in patients having liver resection specifically. The role is called the CIRCULATE study. The role of circulating tumor DNA in resectable metastases is a few things. It might be able to identify patients who have more aggressive disease, who maybe would not benefit from liver resection at all. It also may have a role to play in surveillance after liver resection in terms of detecting recurrence and prompting further tests. It's also being investigated quite a bit to try to guide adjuvant chemotherapy. The trouble with that is we don't really have good adjuvant therapies currently, but there is work going on that's looking at different adjuvant therapies and potentially using circulating tumor DNA to guide that. So those are the potential roles for it. Right now, what we do know is that it is very prognostic. So if we look at patients who have circulating tumor DNA positive after surgery compared to those who are negative, we know that it's very prognostic. And virtually all patients who have positive circulating tumor DNA, virtually all patients have recurrence of their disease. So it is very, very sensitive at picking up residual disease, really, is what it represents, even apart from, it's not even recurrent disease because we're measuring it quite early, just a month or so after liver resection. So we do know that it's very sensitive at picking up residual disease. The trouble is when we've done this, it's not clear what to do about that. So some medical oncologists have used it to guide adjuvant chemotherapy. So you do a liver resection, you measure circulating tumor DNA after the liver resection, and if it's positive, you give patients chemotherapy. If it's negative, you do not give them chemotherapy. So that's a nice strategy philosophically, but the trouble is we don't really know, in that we feel good about the circulating tumor DNA negative patients, that they're less likely to have a recurrence. We don't know in the ctDNA positive patients whether we're actually helping them very much by treating them earlier with chemotherapy, or whether we're just delaying the time until we actually see the residual disease show itself. So that's an area of ongoing research. I'm not going to get into this data too much, but just to say that that's a challenge that we face quite frequently now when we do measure ctDNA after liver resection. So we are using it quite frequently. We're using it, I think it is helpful to help us pick up recurrent disease earlier than we would. And perhaps, if you see a patient who has positive circulating tumor DNA after liver resection, it would prompt us to get MRIs and CT scans more frequently and look for recurrences that hopefully we can treat with ablation or other local treatment options. I think it definitely has a role to play in that. But when we don't see anything, it's a difficult situation because we don't really know whether or not giving patients chemotherapy earlier is going to help them. So it becomes quite a difficult decision when we see that. So I think I will stop there and thank you for your attention during the talk. And I'm look forward to interacting with many of you in the future in a variety of roles. Thanks a lot.
All right. I'll send a big, big thanks to Dr. Karanicolas, both obviously for the effort to get this wonderful presentation, but he also predicted the upcoming ctDNA session happening immediately after his own. So quite the skill set Dr. Karanicolas has. He's also a very highly regarded by every patient that I've come in contact who's been cared for by him. Up next, our silent viewers can now head back to the lobby until our next session, which is at 10:45 with Sarana Ursu. And our coaches will now head backstage for their discussion period, and we will see everybody at 10:45 Eastern Standard Time.